My name is Jessica Martinez, and I've been a surgical technologist at Mayo Clinic in Rochester, Minnesota, for 18 years. I work in the operating room, standing at the surgeon's side, handing instruments, maintaining the sterile field, ensuring every surgery runs smoothly. I'm not a doctor or a nurse. I'm the person who makes sure the right tools are available at the right moment. I've assisted in over 4,000 surgeries. I know the rhythm of the choreography team. But on October 12th, 2023, during a routine gallbladder removal, I started seeing things no one else could see. While the surgeon operated on one set of organs, I saw them operating on completely different anatomy. While the cameras recorded an appendectomy, my eyes watched a tumor resection. Reality split, and I was the only one who could see both versions. Mayo Clinic is one of the most prestigious medical centers in the world. Our operating rooms have high-definition cameras that record every surgery, advanced monitoring systems, state-of-the-art tool. Everything is documented, observed, verified, or so I thought. I grew up in San Antonio, Texas. My mother was a hospital housekeeper, and I'd visit her after school, fascinated by the medical world. I found surgical technology, a way to work in the or without being I moved to Minnesota for the Mayo program in 2005, completed my training, and never left. 18 years later, I'm senior surgical tech in general. I train new techs, handle complex cases, work with the best surgeons in the world. I'm precise, reliable, observant, maybe too observant. October 12th, 2023, started as an ordinary. I was scheduled for a full day in or 3 cases total. The first was a laparoscopic cholecystectomy, a minimally invasive gallbladder removal. Standard procedure, about an hour. The patient was a 52-year-old woman named Carol Pearson, presenting with chronic cholecystitis, inflammation of the gallbladder causing severe abdominal pain. The surgical plan was straightforward: make small incisions, insert a camera and instruments, remove the diseased gallbladder, close up. Routine. Dr. Sarah Kim was the attending. I'd worked with her hundreds of times. Excellent technical skills, calm under pressure, clear communication. We prepped the patient, established the sterile field, and began the procedure at 8:15 a.m. Dr. Kim made the initial incisions, inserted the laparoscope. The video monitors around showed the interior of the abdomen, liver, gallbladder, surrounding structures. Everything looked normal, but when I looked directly at the patient, not at the monitor, I saw something different. The gallbladder on the monitors appeared inflamed, but otherwise unremarkable. But when I looked at the actual surgical site with my own eyes, I saw something else entirely: a mass, a large, irregular mass wrapped around the gallbladder, extending into the liver. It looked like a tumor. I blinked, looked back at the monitor. They showed normal anatomy, just an inflamed gallbladder. I looked at the patient again. The tumor was still there, clearly visible, distinctly abnormal. Forceps, Dr. Kim said. I handed her the forceps, my hands moving automatically even as my mind. What was I seeing? A hallucination? A trick of the light? I watched Dr. Kim work. On the monitors, she was carefully dissecting around the gallbladder, separating it from surrounding tissue. Standard technique. But with my own eyes, watching her hands directly, I saw her doing something different. She was carefully working around the tumor mass, taking tissue samples, examining the abnormal growth. Her movements were precise, deliberate, addressing the cancer I could see, but that didn't appear on any of the screen. Everything okay, Jess? Dr. Kim asked, noticing my hesitation. Yes, sorry, just checking the instruments. The surgery continued. For the next 40 minutes, I experienced 2 simultaneous realities. The monitors showed a routine gallbladder. My eyes showed a complex tumor resection, with Dr. Kim carefully removing cancerous tissue, preserving surrounding structure, addressing malignancy that shouldn't have been there. When the surgery concluded at 9:03 a.m., the monitors showed successful gallbladder removal, specimen bagged for pathology. But what I'd watched was a partial hepatectomy, removal of tumor and affected tissue. In the recovery room afterward, I pulled up Carol Pearson's medical record on my tablet. Preoperative imaging, ultrasound and CT scan showing chronic cholecystitis, no masses, no tumors. Operative report being dictated by Dr. Kim. Laparoscopic cholecystectomy performed without complication. Gallbladder removed intact, sent to pathology. But I'd seen a tumor. I'd watched Dr. Kim remove it. Why was everyone else seeing something different? I told myself it was fatigue, stress, maybe I needed new glasses. But I couldn't shake the feeling that what I'd seen. 3 days later, on October 15th, pathology results came back on Carol Pearson's gallbladder. The report noted not just chronic inflammation, but also incidental finding of adenocarcinoma cells in margins of resected tissue. Cancer, just as I'd seen during the surgery. But according to all imaging, all documentation, all operative reports, there shouldn't have been any cancer. It was described as an incidental finding, unexpected, surprising. But I'd seen it. I'd watched Dr. Kim remove it, the tumor that existed in one reality, but not the other. On October 19, I scrubbed for an emergency appendectomy. The patient, David Chun, 28, had severe right lower quadrant pain, fever, elevated white count. Classic appendicitis. Dr. James Rodriguez began at 2:47 p.m. On the monitor, inflamed appendix, swollen, ready to rupture. Textbook acute appendicitis. With my own eyes, the appendix looked normal, but nearby, a perforated section of small intestine, leaking contents into the abdomen. A bowel perforation, far more dangerous. The monitors showed routine appendectomy, 47-minute. My eyes showed emergency bowel. David Chin recovered perfectly. No complications, discharged in 2 days, which meant Dr. Rodriguez had repaired the perforation, even if the record said he'd only done an appendectomy. 2 surgeries, 2 reality splits. In both cases, what I saw with my own eyes predicted the actual pathology or the real problem better than what the cameras and documentation showed. I needed to understand what was happening. On October 23rd, I requested a meeting with Dr. Kim. We met in the surgeon's lounge. Dr. Kim, I have a strange question about the cholecystectomy on October 12th. The one with the incidental cancer finding? What about it? When you were operated, did you see the tumor? Before you removed the gallbladder? She looked at me confused. There was no visible tumor during the operation. The imaging showed only cholecystitis. The cancer cells were found by pathology after the fact, in the tissue margin. Why do you ask? I thought I saw, never mind. I must have been mistaken, but I hadn't been mistaken. I'd seen the tumor clearly. Dr. Kim had operated on it, even if she didn't remember doing so, even if the cameras showed something different. Over the next 2 weeks, the phenomenon continued. Every surgery showed me 2 reality. A thyroid biopsy that the monitors showed as routine, but my eyes saw as complete thyroidectomy for aggressive cancer. A hernia repair documented as straightforward, but I watched the surgeon remove gangrenous intestine. A knee arthroscopy that appeared simple on screens, but I observed complex bone tumor resection. In every case, pathology or post-operative results aligned with what I'd seen, not what was documented. Patients recovered from procedures they supposedly never had. Cancers were incidentally found that I'd watched surgeons deliberately. On November 8th, I scrubbed on a case that forced me to see. The patient was a 17-year-old girl, Emily Watson, scheduled for removal of a benign ovarian cyst. Routine gynecological, expected duration 90 minutes. Dr. Lisa Park was operating. Laparoscopic approach, camera inserted, monitors showing the ovaries and surrounding structure. On the screens, a simple cyst on the right ovary, about 4 centimeters, consistent with imaging. Through my own eyes, a massive, irregular tumor engulfing both ovaries, extending into surrounding tissue. Not a benign cyst, aggressive ovarian cancer. I watched Dr. Park work. On the monitor, she drained and removed a simple cyst. With my eyes, I saw her performing a total abdominal hysterectomy with bilateral oophorectomy, removing uterus, both ovaries, affected tissue. This was a 17-year-old. If Dr. Park was really removing her reproductive organs, that decision needed to be documented, consented, discussed with the family. But according to the monitors, none of that was happening. Just a simple cyst removal. I couldn't stay silent. Dr. Park, I said carefully, can you pause for a moment? She looked up surprised. Surgical techs rarely interrupt. What is it, Jess? I think I see something on the left. An irregularity. Dr. Park looked at the monitor. The left ovary looks normal to me. We're only addressing the right cyst. Could you examine it directly? With the camera, she moved the laparoscope camera, focused on the left ovary. Jess, I don't see anything abnormal. Everything looks fine. I looked at the monitor. She was right. On the screen, the left ovary appeared normal. But when I looked at the actual surgical site, I saw extensive tumor involvement. I'm sorry, I said. I thought I saw something. My mistake. The surgery continued. Dr. Park completed what the monitors showed as a simple cyst removal. What I saw was a radical cancer surgery that would save Emily Watson's life, but would also render her infertile at age 17. After the case, I pulled Emily's preoperative consent. She and her family had consented to laparoscopic ovarian cystectomy only, not hysterectomy, not removal of reproductive organ, but I'd watched it happen, whether documented or not, whether consented or not. Emily Watson had undergone a complete removal of her reproductive system. I went to the pathology department and requested to see the specimen from Emily's surgery. The lab tech showed me a container with a small cyst, about 4 centimeters, consistent with what the operative report described. But that wasn't what I'd seen. I'd watched Dr. Park place a much larger specimen, uterus, both ovaries, surrounding tissue, in the pathology container. "Is this everything?" I asked. "No other specimens from this case, just the cyst." "Why?" I didn't know how to explain. The specimen I'd seen Dr. Park remove didn't exist in this reality, only in the one I could see. 3 days later, pathology reported benign serous adenoma on Emily Watson. Routine finding, consistent with preoperative. I checked on Emily's recovery. She was doing well, no complications. Discharged 2 days post-op with instruction routine follow-up. But I knew the truth. Emily Watson had been treated for aggressive ovarian cancer, even if the documentation said otherwise. On November 15th, I requested a meeting with Dr. Robert Chen, the chief of surgery. "Dr. Chen, I need to discuss something unusual I've been experiencing in the OR." "What kind of unusual?" I chose my words carefully. "I've been noticing discrepancies between what I observed during surgery and what appears in documentation and on monitors." "What kind of discrepancy?" "I see more extensive procedures recorded, tumor removals that aren't documented, complex interventions that appear as routine procedures in the operative report." Dr. Chen studied me. "Are you suggesting our documentation is inaccurate?" "I'm saying what I see with my own eyes doesn't match with the cameras." "Jessica, you're a skilled surgical tech, but you're not a surgeon. The cameras capture exactly what's happening. If you're seeing discrepancy, it's possible you're misinterpreting but the pathology results support what I'm seeing." Carol Pearson had cancer that I saw during the surgery, but that wasn't visible on imaging. Emily Watson had a benign cyst. The pathology was clear. But what if she actually had cancer and Dr. Park removed it, and that's why she's going to be fine? What if the truth is different from what we're documenting? Dr. Chen's expression grew concerned. "Jessica, are you feeling all right? Have you been under undue stress?" "These suggestions you're making, that reality is different from our documentation, that cameras are recording false information, these are concerning ideas." "I know how it sounds. I think you should take some time off, rest. Maybe see employee health service. We can have another tech cover your shifts while you get some support." I was being sent home, told I was stressed, unreliable, possibly because I was seeing the truth that no one else could see. I took a week off as recommended. I spent the time reviewing every case I'd worked since October 12th, 23 surgeries where I'd observed reality split. 23 cases where my observations didn't match the documentation, but did match the actual outcome. Patients who should have had complications didn't, because surgeons had addressed problems that were never officially acknowledged. Cancers were found incidentally that I'd watched being deliberately removed. Emergency repairs were performed that operative reports never. The evidence was overwhelming. I was seeing true medical reality, what was actually happening to patients' bodies, while everyone else saw a sanitized, simplified version recorded by cameras and documented in chart. But if I tried to explain this to anyone, I'd be dismissed as delusional. I'd lose my job, my career, my credibility. Who would believe that one surgical tech could see truth that advanced medical technology couldn't capture? On November 27th, I returned to work. I said nothing about I scrubbed on procedures, handed instruments, maintained the sterile field. I watched 2 realities play out simultaneously, and I kept my mouth shut. But on December 3rd, a case came through that I couldn't ignore. The patient was a 6-year-old boy, Michael Torres, scheduled for removal of a presumed benign brain tumor. The imaging showed a small, well-defined mass in the left frontal lobe. The surgical plan was straightforward resection, remove the tumor, preserve surrounding brain tissue, expect full recovery. Dr. Angela Martinez was the neurosurgeon. Brilliant, precise, one of the best pediatric neurosurgeons in the country. The surgery began at 9 a.m. Michael was positioned, head secured, craniotomy performed to access the brain. On the monitors, I saw exactly what the imaging had shown. A small, discrete tumor mass, clearly defined borders, easy to resect. Through my own eyes, I saw something completely different. The tumor was massive, infiltrating throughout the left hemisphere of Michael's brain. Not benign, not well-defined. Aggressive, diffuse, inoperable, and spreading rapidly. I saw Dr. Martinez working desperately, trying to remove as much tumor as possible, knowing she couldn't get it all, watching it regrow even as she resected it. On the monitors, She was performing a routine tumor removal. With my eyes, I was watching her fight a losing battle against aggressive pediatric brain cancer. The surgery took 6 hours, far longer than the planned 90 minutes. On the monitor, it looked like Dr. Martinez was being thorough, careful. With my eyes, I saw her trying everything, resecting, cauterizing, trying experimental techniques to save this child from a tumor that was killing him in real time. When the surgery concluded, Dr. Martinez looked exhausted. Tumor resected successfully. We'll need to wait for pathology, but it appeared benign as expected. But I'd seen the truth. Michael Torres had aggressive, inoperable brain. Dr. Martinez had done everything possible, but it wasn't it. The tumor would come back, probably within weeks. I couldn't let his parents think he's cured. I couldn't let them believe the benign tumor story when I'd seen him dying of. After the surgery, I did something I'd never done. I went to the family waiting room and found Michael's parents. Mr. and Mrs. Torres? I'm Jessica Martinez, the surgical tech from Michael's operation. How is he? His mother asked, eyes red from crying. The surgery went as well as could be expected. Dr. Martinez will speak with you soon about so the tumor is gone? He's going to be okay. I hesitated. If I told them what I'd really seen, they'd think I was crazy. If I said nothing, they wouldn't be prepared for what was coming. I think you should ask Dr. Martinez about scheduling very close follow-up within a few weeks. Sometimes these tumors can be more complicated than initially, but the scans showed it was benign. Sometimes scans don't show everything. Please, just ask about close follow-up and maybe get a second opinion. Mrs. Torres looked confused and worried. Are you saying the doctors that Michael isn't going to be okay? I'm saying please stay vigilant. Please watch him closely. Please don't assume everything is fine just because the surgery went well. I walked away before I could. I'd done what I could without completely destroying my credibility. 3 weeks later, on December 24th, Michael Torres was readmitted with seizures and neurological decline. Emergency imaging showed widespread tumor recurrence throughout his left hemisphere. The benign tumor had returned as aggressive glioblastoma, exactly as I'd seen during the original surgery. Dr. Martinez was devastated. This doesn't make sense. The pathology from his original surgery showed benign astrocytoma. This level of aggressive recurrence shouldn't be possible from that kind of tumor. But it wasn't recurrent. It had been there all along. I'd seen it. The cameras had recorded something different, but the truth was what I'd observed, aggressive cancer that was never going to be cured by one surgery. Michael Torres died on January 8th, 2024, 6 years old. He'd had 5 weeks from his surgery. If I'd spoken up earlier, if I'd insisted someone believe, could he have gotten different treatment? More aggressive chemotherapy from the start? Radiation? Would it have mattered? I carried the weight of his death, knowing I'd seen the truth and not been believed. On January 15th, I requested another meeting with Dr. I need to report something about the reality discrepancies I mentioned. Jessica, we've discussed this. If you're still having these perceptions, you need to seek professional help. Michael Torres died because I saw the truth and nobody believed. Dr. Chen's expression hardened. Michael Torres died from aggressive brain cancer that wasn't apparent on imaging pathology. It's a tragedy, but it's not related to your perceptual issue. It wasn't recurrent. It was there from the beginning. I saw it during his first. If anyone had listened. Jessica, I'm going to be direct with you. Your insistence that you can see things cameras can't see, that you have access to some kind of hidden reality, is concerning from a mental health perspective. I'm putting you on mandatory medical leave pending psychiatric evaluation. I'm not crazy. I'm seeing what's really happening to patients. Then explain to me how it's possible that you, and you alone, can see medical reality that our multi-million-dollar imaging systems, our experienced surgeons, and our video documentation all miss. Explain that using any rational framework. I couldn't. I had no rational explanation. I only had the evidence, patients who recovered from procedures they supposedly never had, pathology that matched what I saw but not what was documented, outcomes that made sense only if my observations were accurate. I'll undergo the evaluation, but I'm right. And more patients are going to suffer if nobody believes me. I was placed on administrative leave on January 16th, 2024. I attended psychiatric evaluation session with Dr. Ellen Morrison. Tell me what you're experiencing, and I see two versions of reality. What the cameras show and what's actually happening. They don't match. And you believe your version is accurate. The outcomes prove it. Patients recover from complications they supposedly never had. After 3 sessions, Dr. Morrison's assessment, possible delusional disorder with specific focus on medical procedure, recommend extended leave and ongoing psychiatric treatment. I was officially diagnosed as delusional. My observations dismissed as illness, but I knew the truth. I was seeing reality that everyone else was blind. And without me in the OR, patients would suffer from misdiagnosis, missed cancers, complications that could have been prevented if someone had been able to see what was really happening. I appealed the decision, requested objective. Put me in an OR, record what I observe, and compare it to pathology results. Let the data prove whether I'm seeing reality delusion. The hospital refused. Too risky, they said. Too liable to keep employing someone with documented psychiatric concerns in a sensitive clinical role. On February 1st, 2024, my employment at Mayo Clinic was terminated. 18 years of excellent service ended because I could see the truth. I spent the next months trying to understand what had happened. I researched perceptual disorders, reality distortions, neurological conditions that might explain seeing two simultaneous versions of reality. I found nothing. No medical condition that would cause specifically surgical reality split. No explanation for why cameras would record one thing while my eyes saw another. Unless it wasn't a perceptual disorder. Unless I'd somehow developed the ability to see true medical reality, what was actually wrong with patients' bodies, while everyone else saw a filtered, simplified version. In June 2024, I received an email from an address I didn't recognize. The subject line read, "You're not alone." I opened it cautiously. Dr. Chin sent me your case file. I'm Dr. Sarah Volkov, psychiatrist, formerly at Bellevue Hospital, New York. I experienced something similar, seeing future pathology, before it developed. I was also dismissed as delusional. But I know we're not crazy. We're seeing something real that medical technology can't capture. If you want to talk, I'm here. You're not alone, Jessica. I stared at that email for a time. Someone else had experienced impossible medical perception. Someone else had been dismissed, disbelieved, diagnosed as mentally ill for seeing the truth. I wasn't alone. I wrote back. We talked. She explained her experience, seeing deaths on scans 48 hours before they happened. I explained mine, seeing true surgeries while cameras recorded false ones. Different manifestation, same phenomenon. Medical reality visible to some people, but not to conventional observation or documentation. What do we do with this? I asked her during one of our calls. I don't know, Dr. Volkov said, but I think there are more of us. People working in medicine who see things that shouldn't be. And I think we need to find each other. Because if we can see truth that medical technology misses, we have a responsibility to use that ability, whether or not anyone believes us. I still don't have my job back. I'm fighting the psychiatric diagnosis, but Mayo Clinic won't. As far as they're concerned, I'm a delusional former employee who can't be trusted in clinical setting. But I know what I saw. I know that for 4 months, I observed surgical reality that cameras couldn't capture. I watched surgeons address problems that imaging didn't detect. I saw truth that everyone else was. And I know that somewhere, right now, patients are having surgeries where the documentation won't match the reality. Where cameras will record routine procedures while complex interventions actually. Where the truth will be hidden from everyone except someone like me. Someone who can see what's really happening. I hope there's another tech in there. Someone who can see what I saw. Someone who won't stay silent, even if no one believes. Because the truth matters, even when it's impossible. Even when it costs everything. Especially then.